not nearly as many things in the pelvis as in the abdomen. So that will make it a lot easier for you. It means actually, I'll show more slides of just pathologies and anomalies, I guess pathologies, because it won't take us very long to go through the actual structures. These are plain films of the pelvis, bony pelvis. One is of a woman and the other is of a man. Gentleman in the red shirt who said hello to me on the way in. Didn't you say hello to me on the way in? It'll teach you not to say hello to me on the way in. One of these is a female, bony pelvis of a female. The other is a plain film of a male. 50-50 chance. Which do you think it is which?
Yeah, I'll go with the left.
The left is a female. You are 100% correct. Why do you say that? Time's up. All right. That's not why. Why do you think it is? You're absolutely right. Here's another clue. This one has a penis. No one ever sees the penis. They're always focused on the bones. All right? But you're right. There is a difference. There is a difference in the shape of the female pelvis from the male pelvis, because the female pelvis is structured so as to provide as much room as possible for the passage of the fetal head during delivery. So one of those things is what's called the subpubic angle, is wider, that's part of the pelvic outlet, is wider in a female than in a male. Also, if you look at the distance between the arcuate lines, they're wider than in a male. And if you look at here, you can see the ischial spine of this male, and you can see the left ischial spine of the male here, and they're completely hidden behind the other parts of the pelvic bone in the female because they are farther apart as well. So these are just to alert you to the fact that male and female pelvis are different shaped as a result of the obstetrical requirements in a woman. This just tells you what's what. The hip bone, the os coxae, like so many bones in the body, start out first as a little cartilaginous representative of what it will be in the fetus. And that cartilage later gets destroyed and replaced by bone. That destruction and replacement starts off in the fetus but doesn't get completed until you're past puberty. And there are 3 sites of bony formation of the hip bone from its cartilaginous precursor. These are called ossification centers. They're separate individual sites where bone starts to replace cartilage. One is for the ilium, the iliac ossification center, one for the ischium, the ischial ossification center, and one for the pubis. And when a child is born, this is pretty much what its hip bone looks like. About equal proportion, maybe, of cartilage and bone. Here is an X-ray of an 11-month-old, and what you see are these 3 ossification centers. You don't see the complete hip bone because they have not yet grown big enough to fuse with one another as they will in puberty. So you can see here the iliac ossification center on this child's right. You can see the ischial ossification center on the right, and you can see the pubic ossification center. It does appear here we do not see the separation of the pubic and ischial centers in the vicinity of the acetabulum, but we see their separation in the vicinity of what's called the ischiopubic arch, and that's called the ischiopubic synchondrosis. Synchondrosis means cartilaginous joining of 2 bony regions. So this is filled with cartilage where I'm pointing, right there. And that's called the ischiopubic synchondrosis. It's the same as this zone of cartilage right here. We also see the fact that the acetabulum, which is this region, is not formed of bone, but is formed to a large extent of cartilage. And you can see that, well, you can't, this would be where the acetabulum would sit. If we go to a little older, I don't know how old this is, where the iliac, pubic, and ischial centers have increased in size, so they almost have fused with one another. You still have an ischiopubic synchondrosis here. You see that the cartilage between the pubic, ischial, and iliac centers in the floor of the acetabulum has 3 arms and is called a triradiate cartilage. So, in fact, this is the zone of the triradiate cartilage right there and right there, but we can't see it except in this, as triradiate, except in this drawing that I'm giving you. Now, we're going to look at CTs of the pelvis. This is obviously a woman because there's a uterus here. And we're not going to see that many things. We're going to do some vasculature, which is not illustrated here at all. In terms of soft tissue structure, we're going to see essentially in the ovaries, fallopian tubes, uterus, both body and cervix, and vagina. We'll see in front of the uterus and vagina, the urinary bladder. Maybe we'll catch the urethra, and behind those things, the rectum. Here is a sagittal reformatted structure of a 29-year-old female. And you can see those things I pointed to. Here's the urinary bladder filled with urine, because urinary bladders aren't normally this expansive if there's no urine in them. Here is the clear fundus of the uterus. And this is the body of the uterus right there. Ooh, need a good imagination to see the cervix of the uterus, which I believe is right here. And that means that this sort of nondescript radio density heading down behind the bladder and inferior to what we would call the cervix must be the vagina. But there's no air in this person's vagina, so we don't see it as that distinct. And the same with the rectum. The rectum is the thing in front of the sacrum, and it's coming down like that, but since this person does not have a lot of air, it just has stool in the rectum, it has the same radio density as the vagina, and so you really don't see a clear boundary for them. Anybody know the name of the space where that thing is pointing is called?
Posterior.
Okay, good, posterior cul-de-sac. And it's filled with a loop of bowel which has barium in it, because even though this person's lying down, well, in fact, that is, when you're lying down, the posterior cul-de-sac is the most posterior part of the peritoneal cavity, so things will settle in there. And in fact, what's settled in there here is a loop of bowel. If the person were standing, there would also be a loop of bowel there, but it also pressed down on the uterus and bladder. This is a microscopic image of an ovary. Ovaries are filled with these fluid-filled sacs, all right, which are called follicles. You haven't done this yet in histology, maybe you did it as an undergraduate. But they are fluid-filled, but there's many of these fluid-filled sacs in the ovary. But because they are filled with fluid and the ovary itself is soft tissue, they have the same radio density as the rest of the ovary. So when you look at an X-ray of an ovary or a CT scan, you're not going to see these things. It's just going to look like a mass of whitish gray stuff. But you'll see why I make this point now, because it'll become important when we look at MRIs. So let's just go right now, concentrating on the vasculature down through the pelvis of a young woman. We know that immediately on the left anterior side of the lumbar column is the aorta. Above L4, the aorta bifurcates at L4. And to the right of the aorta is the inferior vena cava. I'm just, for the sake of completeness, pointing out the psoas major, which sits on the sides, lateral surfaces of the vertebral column. I did not label quadratus lumborum, which is right here and right there, but you know it's there. The inferior mesenteric artery is given off from the front of the aorta at what level, roughly?
L3.
L3, good. So we're down below the origin of the inferior mesenteric artery, and we see its course, which is along the left edge of the aorta. Really. It follows the left edge of the aorta down. The inferior mesenteric vein is, as we know from our abdomen lecture, always to its left. So just go down a level. Nothing interesting is going to happen till we get to the region of middle or bottom of L4, where our two common iliacs arise from the aorta. I changed the name of this to superior rectal artery. Here it's called inferior mesenteric. Here it's called superior rectal. And you have a right to ask why. And the answer is this. When the last sigmoidal branch is given off of the inferior mesenteric, after that it's called the superior rectal. So I had to say to myself, there's a little white dot, I can barely see it, right there, which you can see it a little better right there, a little white dot, which I thought might be the last sigmoidal branch. So I decided it was, whether it is or isn't, and after that I'm going to call this superior rectal. It's not really an important distinction to make, but just for the sake of completeness. So we continue down, and the common iliacs start start to diverge, and we see something coming into the IVC from the left side. And it gets bigger as we come down here. And this thing which is coming into the IVC from the left side, inferior to the bifurcation of the aorta, is the left common iliac vein. Now, when I decide to call, that very clearly is the left common iliac vein. Here is, I've decided to call it right common iliac. We're really right at the formation of the IVC. I mean, it's almost arbitrary. When you're right where these two veins meet, you know, when you change the name to IVC from its two components. So it's more or less arbitrary. But since this is so clearly the left common iliac vein, I decided to change that to the right common iliac. And as we continue down, nothing very interesting is going to happen, to be honest with you. Down, down. All right, now we're seeing the iliac veins, the common iliac veins, more separate from one another. Down. And now I have labeled this the right internal iliac vein and that the right external iliac vein, whereas I've still called this the common iliac. And the only reason I did that is because I know what's going to happen later as I go down the series. This is not typical for the internal iliac vein to join that close to the inferior vena cava is not typical, but in this particular person it did. So, and you'll see if we follow it, it's going to end up doing what the left internal iliac does. So we keep on going down. Here's the common iliac. We see it dividing into two. We see the external and internal iliacs on the left side. We continue down. They are very obviously separate now. On the right side, we start to see something which I'm sure is going to be its internal iliac. And here it is, more obviously separate branch of the common. So now we have external and internal on both sides. And there's nothing very interesting. We can follow these down. And that's all there is to it. The important relationships to note here are that the internal iliac vessels pass posteriorly from the common iliacs, and the external iliac vessels take up a position on the medial surface of the psoas major muscle. And initially, the external iliac arteries are anterior to the external iliac veins on the medial surface of the psoas. Still very obvious on both sides. External iliac artery anterior to vein on the medial surface of the psoas. But as we continue to go further down, and I hope I'm going down, yes, they will change their relationship with the vein taking up a position medial to the artery. So there's a 90-degree there is a 90-degree rotation, and by the time we leave the pelvis, the external iliac vein is medial to the external iliac artery, and when they enter the thigh as the femoral vein and femoral artery, it is the vein that's medial to the artery. Now for the actual organs of our female, here's an organ in front of the sacrum. That's obviously the rectum. That's what sits in front of the sacrum. Here's something popping into view in front of the rectum. This being a woman who has her internal organs intact, this is going to be the uterus. That's the thing which is in front of the rectum. Keep on going down. Here's something that I fancy might be a fallopian tube. This sort of looks like it could be. It's coming out of one of the upper corners of the uterus, but I wouldn't bet $1,000 on it. Keep on going down. Now I might bet more because I think this little solid structure right here is an ovary. I'm pretty sure it's an ovary, as is this one right here, but as none of those fluid-filled follicles stand out in relief. So it's just sort of a nondescript mass in the lateral sides of the pelvis, not too far from the uterus. And the urinary bladder has been coming into view also as let me go back up at the top. Uterus, now we see the beginnings of the top of the urinary bladder. And none of this is going to change. You know, we're just going to go down here. Eventually, the uterus will get narrow as it becomes goes from the body to the cervix. Then it will turn into the vagina. The ovaries will eventually disappear from view. The rectum will stay there all along. The urinary bladder will stay there. I'm still calling this uterus. So rectum, uterus, bladder. Ovaries are gone. No change, no change, no change. At this point, I've decided to call it vagina. Now, Does it look any different here than there? No. Looks no different at all. I called it vagina because, in my opinion, in my imagination, I thought this is where the external os of the cervix was. I thought this was cervix in this person. And everything below that must be vagina, and that coincided with the tip of the coccyx. So in these CT scans, when I got to the tip of the coccyx, which is right there, I changed the name to vagina. But there's no possible way that you can tell just from looking at a CT scan when cervix passes to vagina. They all look the same. And then we just continue down, nothing all that interesting. Just some muscles of the pelvis that are in this region. The obturator internus, which you know forms the lateral wall of the ischiorectal fossa. The fat-filled ischiorectal fossa, that's why it has a fat density. And urinary bladder is starting to get smaller. This thing with a little black dot into it, which appears to emerge from the posterior region of the bladder, in my opinion, is likely to be a urethra. The urethra sits at the anterior wall of the vagina, so that has a good relationship for the urethra. And continuing down, I'm pretty convinced that's the urethra there, vagina and rectum behind it, and nothing exciting. You can see some muscle here. The muscle was there here as well, but the muscle that's formed the medial wall of the ischiorectal fossa, which is the pelvic diaphragm or levator ani, is of the same radiodensity as is the rectum and the vagina and all of those things. So it doesn't stand out in relief here. As we go further down, we got to a zone where there might be a little bit of fat between on the inside of the pelvic diaphragm. So now I can see actually a sheet of muscle on one side and the other, which is the levator ani or pelvic diaphragm. Here we had still urethra, vagina, rectum, pelvic diaphragm, ischiorectal fossa. We go down another level, and now we see a triangular bridge between the ischiopubic ramus on the right and left sides. And the triangular bridge of tissue in women, well, it's in men too, between the two ischiopubic rami is the perineal membrane, so I think that's what that must be. We keep on going further down. Still we see perineal membrane. Now we see something on the inferior surface of the perineal membrane, more clearly on the left side, which must be up against the ischiopubic ramus, so that must be the crystal of the clitoris. And we see some things here which are below the perineal membrane on either side of the midline, which must be the bulbs of the vestibule. And as we continue down, pretty much everything disappears. So that's it. I mean, it's really very easy to read pelvic CT of a woman. These are going from anterior to posterior. I'm not going to go through all of these. I've only labeled a few things. Thought I'd show you this. Did you mention the pyramidalis?
In lab.
Oh, but not in it. All right. Not everybody has a pyramidalis. I thought this was it. All right. In lab, it should be a nice, beautiful triangular. The two of them together form a nice triangle with the apex pointing to the linea alba. And so when you get to your clinical rotations in OBGYN, you would think that this muscle is of no significance whatsoever. Functionally, it's of no significance. But from a clinical point of view, obstetricians, gynecologic surgeons and obstetricians, if a woman is fat or has had previous surgery, it can be sometimes hard to identify the linea alba. And if she has a pyramidalis, that is what you're looking for. Because the two pyramidalis muscles make a triangle with the apex pointing superiorly, and that apex points to the linea alba. So you know where it is if the person has a pyramidalis. So that's why we don't ignore it completely. So we're going further backwards. I'm not going to go through most of the stuff. Of course, the first thing we come to is the bladder. Once you're behind the abdominal wall, you come to this woman's bladder. Keep on going backwards. After the bladder, we expect there to be a uterus as we go backwards. We'd like there to be a uterus. A trick thing. You can tell me what that is. Because it's one on either side. I've run into it, and now if I go backwards, and backwards I run into psoas. Now, I heard the word ureter come out, and that's a reasonable guess, although I doubt very much whether this is the ureter, because, and I'll tell you why, you see this thing here? It's crossing. Oh, that wouldn't be a good reason, would it? I wonder if I don't think it's the ureter. Well, I didn't think it was the ureter, but now I wonder. Let's see if we can. I'm tracing it forward now. Yeah. I thought I'm going backwards again. You know why I don't think it's the ureter? I knew there was a reason. See how it's sort of heading medially on that side? Oh, but now it's not anymore. I don't know. Well, if it were, all right, so, you raise a good question. Well, all right, if it weren't the ureter, what would it be? Yeah, it would be a gonadal artery, which is what I thought it was.
Would the left be gonadal?
But can I prove that it's not a ureter?
They might not both be the same thing.
You think that's a good point. They might not both be the same thing. But you should see, if you're going to see a ureter on one side, you're going to see it on the other.
I mean, if it were gonadal artery, then there should be a ureter posterior to it. You think you didn't catch that?
Well, the ureter will be, the sequence on the left side, the sequence is always inferior mesenteric artery, ureter, gonadal vessels. The gonadal vessels cross over the ureter and then descend. And on the right side, there's no inferior mesenteric artery, but again, the gonadal vessels cross over the ureter and then descend.
What did you say? I mean, you said inferior mesenteric.
On the right side, there's no inferior
Ureter,
mesenteric.
gonadal vessels?
Yes.
From anterior to posterior?
No, from right to left. As you're going from the midline out to the side, it's inferior mesenteric artery, ureter, gonadal vessels. The inferior mesenteric artery, or superior rectal, crosses the common iliac coming down. The ureter crosses the bifurcation of the common iliac coming down. The ovarian vessels cross the external iliac coming down. So they again cross the iliac vasculature from right to left. Inferior mesenteric crossing the common, ureter crossing the bifurcation of the common, ovarian crossing the external iliac. Now, what is this crossing? Where is the bifurcation? I'm having a tough time. Is the bifurcation there? I guess I don't know what it is, but I guess I don't care. In the sense that I was trying to talk about relationships, and I've done that. I sure would like to know what it is. Oh, really? But I don't know what it is. What makes me doubt it's the ureter. What makes me doubt it's the ureter is that I won't be able to trace it up to continuity with the kidney. So I go further and further backwards, 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 backwards. Here's the kidney on the right side. Here's the kidney on the left side. Can we actually see the ureter? Ah! That's the clue we needed. I'll tell you why that's the clue we needed. We can't see. The renal pelvis is not filled with contrast. All right? That means that the contrast has not passed into the pelvis and ureter in this person yet. All right? So if the contrast has not yet passed into the ureter, then this thing is not the ureter, because that has contrast in it. It has intravascular contrast, which is derived from the fact that it branched from the aorta. So I was right, but I never gave any thought as to why I was right. All right? This is known as problem-solving anatomy. Okay? So these really are the gonadal vessels, or the ovarian vessels in this woman.
Dr. Stern?
Yeah.
I'm sorry. How do you see that those have contrast?
How do I see that they have contrast? Because they're white. Whatever this is, it's a white, linear white thing of the same radiodensity essentially as the aorta and the iliac vessels. So they have contrast in them. If this person did not have contrast, You would not, in any way, shape, or form, be able to distinguish the gonadal vessels from the psoas. They would just be all the same radial density. Now, the point was, well, you know, if the person had secreted the contrast into the ureters, then they would stand out too. But contrast has not reached the ureters in this person, so we're okay. So I'm okay. Here's, by the way, the inferior mesenteric artery arising from the aorta. And we're just going backward. I can't even remember which is backward. Forward. All right, so that's, let's go back and look at, here's our bladder. I got totally sidetracked by my ureter ovarian artery issue. Here's the bladder. We continue to go backwards. Here's the uterus, which in this person is sort of leaning over and sitting on top of the bladder. That's fine. We keep on going backwards. Likely ovary would be my guess. No, it could be bowel. I think it's bowel. Because I think that's ovary, and that's ovary there. This has little air pockets in it, so I think it's bowel. So this must be ovary, ovary, uterus as we go backwards. Keep on going backwards. Still ovary, ovary, uterus. Keep on going backwards. And that clearly is bowel, because now we see contrast in it. And that's bowel there, so there's contrast. This person swallowed barium. And then behind the uterus is nothing but the rectum, wherever it is. All right, don't care about that anymore. Bowling. All right, this is a axial CT scan through the uterus. You can actually see its wall, and you can see its lumen in this person. You can see the ovary on both sides, or at least what I think is the ovary. What I really wanted to show you in this, here's a line from the linea alba to the middle of the sacrum. And the uterus is off to the side of that median sagittal line. And if you look at the view in coronal section, again, you can see the uterus is off to the right side. That is very, very typical. You should not expect people's uteruses, to be in the middle. They often are a little bit to the right or a little bit to the left. So don't be surprised when you're looking at these things if they're not right in the middle. Oh, so I thought these were about as nice ovaries as you're ever going to see in a CT scan. They're not that great, but still they're about as nice as you're going to see in a CT scan. And really, how do you make that determination? I mean, you got a uterus and you got two sort of oval-shaped things on either side of it. And they don't really look like anything, but two little oval-shaped things on either side of the uterus are likely to be ovaries. Now, we get to, if you really want to see ovaries, you go and do an MRI. This is an MRI of a T1 weighted MRI and a T2 weighted MRI. And you remember the big difference between them was that standing fluid, which is not high, if the fluid is not high in protein content, standing fluid is bright white in a T2 and not that way, so it was black in a T1. So same person, just shown in T1 and T2. Here's the urinary bladder filled with urine, but the urine looks like black stuff in a T1 and looks like white stuff in a T2. Here's the uterus. Uterus itself doesn't change that much in appearance, but now you can see all those follicles in the ovary because they're filled with fluid. So if you want to see an ovary, you do a T2 weighted MR and you can see it. Gorgeous. What is this? This is interesting. This is what it is. I was just telling some gentlemen about the development of the fallopian tubes. Now you've all, I know, done your embryology, and you know about the fallopian tubes developing from the paramesonephrine or Mullerian ducts, and how they come together as you pass inferiorly, merge with one another, and become the uterus. So there are these two tubes which merge to become the uterus. And in some large proportion of people, that merger is complete. You have a single uterus. But in some people, the merger is incomplete, and your uterus has two projections from it. It has two components, which are called horns, and that's called a bicornuate uterus. You cannot really tell at all in this T1 weighted that this is You can see it's sort of lumpy, but uteruses can be lumpy because they can have fibroids or anything. But you can't really tell that there's something odd here. But in the T2 weighted, you see the actual uterine cavities of the two different horns of the uterus. So I just thought that was interesting to show bicornuate uterus. All right, here's the same in a coronal, same sex, same person, coronal MRI, and again you can see the uterus and you can see the two separate cavities of the two horns of that bicornuate uterus. Ovarian cyst. You see that what we might like to call an ovary in the T1 weighted on one side is much larger than what we might want to call the ovary in the left side. But in the T2 weighted, now, look, there's one difference here. FS, you see the FS there? This is T2 axial FS. FS means fat suppressed or fat saturated. It is possible to block the signal from fat. Here's a T1 and T2 without suppression of the fat. So fat is bright white in the T2 and fat is bright white in the T1. There's really no difference unless you do this thing called fat saturation or fat suppression, as was done here, and that takes the signal from fat away. And it's often very useful to take that signal away because it clears up a lot of things. In this case, it was this is a fat saturated, so you don't see all the fat, but you see the big ovarian cyst on the ovary on this side. Maybe she didn't have any follicles. She might have been, well, 39-year-olds should not be menopausal, so I don't know why we're not seeing follicles, but we're seeing the big cyst on the right side. I know Dr. Larson went into a discussion of the difference between retroflexion of the uterus and retroversion of the uterus. The version angle is the angle between the vagina and the cervix, and the flexion angle is the angle between the cervix and the body of the uterus. So in this case, this is the normal is this dotted line thing here, because there usually is, I don't know what, 135 degrees or so. But if it's a 90-degree angle, that's markedly antiflexion. And if it's backwards, that's retroflexion. And here again, the normal angle between cervix and vagina is, I don't remember, close to 90 degrees. And you have various degrees of retroversion. Now, I tend to remember everything without aids to my memory. But some things I cannot remember without aids. That is, I cannot remember the difference between retroversion and retroflexion unless I think that version begins with a V and vagina begins with a V. So retroversion, the version angle, refers to the angle between cervix and vagina. And I know the other angle between body and cervix is the flexion angle. That use of that relationship between the first letter of vagina and the first letter of version is called a mnemonic device. All right? It is not called a mnemonic device. And I understand from some of my colleagues that you people often use, as has every class before you, referred to, I have this mnemonic aid for learning things. Mnemonic is a plague that kills people. Mnemonic or mnemonic is a memory device. It is extremely important throughout the rest of your life. You do not ever refer to a memory device as a mnemonic device. So that's why I wanted to show this slide. I tell you, I told this story at lunch. Every year that I taught this course, I make the same point. One year, a student of mine who wanted to go into family medicine and got a subscription to the Family Medicine Journal, read an article in the Family Medicine Journal about, really printed out in letters, mnemonic devices for learning the names of something. And she was so upset and alarmed by this that she wrote a letter to the editor, which was published in the Family Medicine Journal, pointing out that there's no such thing as a mnemonic device. There's only a mnemonic device for learning things. So it does happen, and you will never make that mistake yourself in your publications. All right, this is a sagittal. These are just goofy things that I'm showing you. This is a retroflexed uterus. You can see the cervix here. The same. These are just T1 and T2. This is fat saturated or fat suppressed. You can see very clearly here. Look, this is the bladder. Look how funny. I mean, well, I don't know why the bladder is just really long and tall in this person, but I don't know if that's responsible for pushing. But here is the cervix, and we expect the uterine body to head forward from the cervix, but here the uterine body is actually heading either absolutely in line or it looks a little backwards from the cervix. So this is a retroflexed uterus, angle between body and cervix. Here is, what the hell is that? Markedly retroflexed, yes. Well, I can barely even see what's going on. Oh yeah, here's the cervix here. Here's the body there. So that's a marked retroflexion between cervix and body. Here's one that here's the cervix here. And here's the body there. So there should be, the body should head forward, but here it's straight line or backwards. So that's a retroflex. But here the angle between the cervix, which is this white stripe, the lumen of the cervix, and that white stripe, which is the lumen of the vagina, is also greater than 90 degrees. So that's a retroverted and retroflexed uterus. Now, is it really important that these, every radiologist who sees these reports it on the, when they write their report, they say markedly retroflex, retrovert. These things are considered normal variants of uteri. Some people still think they might cause chronic pelvic pain, but most people just consider them normal variants. Here's T1, T2, not fat saturated, so the fat looks good, of a uterus. Oh no, looks fine to me here. But when you look at it in the T2, it has this big, very dark thing there. That big dark thing is a uterine fibroid. All right, it's a fibromuscular, smooth muscle, fibrous tissue, benign tumor of the uterus. Here it is seen in sagittal, the same person, seen in sagittal. Here's the uterine fibroid. Here's the cervix and vagina, so that's a normal angle there. And here in the T2 fat saturated, the fibroid stands out even in greater relief. I'm not sure I can tell you why, but it does stand out in greater relief. Here is a person with lots of uterine fibroids, lots of them. Here is the treatment. I think the treatment's discussed in clinical sidelights, one of the treatments. When you have this many uterine fibroids, it really does cause pain and dysmenorrhea and things of that nature. So they try and get them down in size. They should just do hysterectomies for women like this. Now they try and kill the fibroids selectively by injecting microemboli into the uterine artery. And the loss of blood supply apparently affects the fibroids more dramatically. The loss is not permanent, but the immediate loss apparently affects the fibroids more dramatically than other uterine tissue. And so here is what it is prior to microembolization, and here it is afterwards. And now the fibroids have turned from what looked like healthy tissue before the embolization to what looks like dead tissue after the embolization. So this is a good result, and these things eventually will get smaller and smaller with time if they are truly dead. Here's the same person. This is a axial view. That other one clearly was sagittal. This is an axial view. Here are, they don't correspond exactly because they're taken 5 months apart. These are living fibroid, living fibroid, living fibroid, living fibroid, living fibroid. Dead, 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 and one that didn't die. So you do these MRIs after you do this embolization because sometimes they don't die. Sometimes you didn't embolize one, the arterial supply of one adequately, and it stays alive. And I do not know what they do about this, to be honest with you. I just thought it was interesting to show you. This I thought was just so cool I could not show you. This person had an MRI done because they suspected there might be a vertebral anomalous development in the child she was carrying. So this is a fetus. Here's the spinal cord, spinal column of the fetus. Here's its brain, which hardly looks like anything. Here's its eyes, if it's looking at you. If its nose, its mouth. I guess its heart, was a centering heart and lungs. I just thought it was really neat to see an MRI of a fetus.
How far along?
It turned out nothing was wrong with that fetus. Everything was fine. Men, all right, differ from women. Men have no uterus and have a prostate gland and seminal vesicles. That's essentially it. Or the old Mr. You want to know who Mr. Rogers is? You know what his most famous quote about men and women are? Men are fancy on the outside. Women are fancy on the inside. Everybody's fancy. Everybody's special. And then he went on. All right. So, then, you don't know? Go to YouTube. Do a search for Mr. Rogers, Men and Women, or Men Are Special, or Women Are Special, and you'll hear him sing this song. It's a great anatomical song. But you're all special in different ways. All right? Here's a sagittal view of the man. Here's the rectum sitting in front of the sacrum. Here's the urinary bladder sitting behind the anterior abdominal wall. Here at the base of the urinary bladder is what I determined to be the prostate. And here, superior to the prostate and posterior to the bladder, are the seminal vesicles and vas deferens. I remind you, if we go here to this drawing, you have a bladder. At the base of the bladder is the prostate gland through which the urethra passes. Superior to the prostate and posterior to the bladder, and between the bladder and rectum are the seminal vesicles, which are right here, and vas deferens. In an axial section, we'll just go down very quickly. I'm not calling this the rectum yet. I'm not calling that the rectum yet, because by definition, the definition of the rectum, and when you identify it on CT, the definition of, you know what Taenia coli are? Sure, they know what Taenia coli are. Taenia coli, the rectum has two of them. The sigmoid colon has two of them. Sigmoid colon has two Taenia coli. When those did sort of spread out and become a continuous coat around the outside of the bowel and lose their integrity as distinct linear bands, that's when the sigmoid turns into the rectum, by definition. So the rectum begins when the taenia are lost and the longitudinal muscle becomes evenly distributed. That usually occurs around S2 or S3. So we're up here much too high for that to have occurred. I could never tell on a CT anyway, but I don't usually call anything rectum until I get around the S2 or S3 region. But this man's bladder, he's got a lot of urine in it, so it's really expanded. Now I'm getting to where I might want to call that the rectum, and that the bladder. And if we continue to go down, rectum, bladder, rectum, eventually I expect to see something in between rectum and bladder. That would be the seminal vesicles and vas deferens. So if I keep on going down, I hope to see them. Where are they? Here they are. The two seminal vesicles. Now I know that the vas deferens is probably, because the vas deferens is always medial to the seminal vesicles. So I probably have seminal vesicle and right there vas deferens, same, but I don't see them as distinctly separate structures. This appearance of the seminal vesicle is called the bow tie appearance because it looks like a bow tie. And that is the way all radiologists identify seminal vesicles. They look like a bow tie on the back of the bladder between it and the rectum. We go down another level. I actually thought I could see a vas deferens on this side right there. I don't know if it's true, but I thought I could see it. If we continue further down, we'll eventually get below or inferior to the seminal vesicles, and we'll get to the prostate gland, which they sit on top of, and here it is. And the prostate gland is, underneath the base of the bladder, and we continue down, and nothing exciting. Here's our pelvic diaphragm. In theory, in reality, there's a urethra through the middle of that prostate, but I can't see it because it's collapsed. And that's it. And then we get further down, and we start, I guess I don't show these things. Oh, I'll show them later, the male fanciness on the outside. Here are two seminal vesicles that look like a pretty crappy bow tie, right? Because not everything looks as beautiful as you would want it to look. But they're sitting as two sort of nondescript things between the bladder and the rectum, so they must be seminal vesicles. We'll continue further down. Prostate's going to show up here. Ah! Look at this. This is the spermatic cord. So in there are the vas deferens and the testicular artery and testicular veins and things. Here we're going to see it piercing me through the superficial ring. And here it is outside, the spermatic cord outside. And then it'll go into the scrotum. Follow these two spermatic cords. heading down to the scrotum. Here's the male perineal membrane, in my opinion. This must be the crus of the penis on either side, joining to become the corpus cavernosum. And this must be the bulb of the penis, which if we follow, will turn into the corpus spongiosum. And in fact, here's the corpus spongiosum. And then here's a cross-section of our penis with the corpus cavernosum and the corpus spongiosum on the ventral side. Male. Bladder, if we go backwards, we expect to see prostate eventually coming into view underneath the bladder. And here it is. That must be the prostate right there. What else could it be on the undersurface of the bladder? We continue going backwards. Still we see prostate and bladder. Continue going backwards. These could be ureters, but I'm not certain. I doubt it. I don't know what they are. We go backwards further. Bladder is getting smaller and smaller. We're getting to, we're eventually in the region behind the bladder, and yes, indeed. Now we see the things behind the bladder, the two bow tie things, the seminal vesicles, which are behind the bladder, and then we'll come to rectum. Oops, well, that was rectum there. Let me go forward. I thought I saw even, oh, look at that. That's what these things are. These are vas deferens right here. Right there. And they're going to run down there between the two seminal vesicles. Regular T1, T2, fat saturated, urinary bladder, urine and urinary bladder. Look at seminal vesicles light up in a T2. And I don't know why, but they do. I mean, they have fluid in there. They have some of the fluid that will become part of your semen. But I would have thought it would have been highly proteinaceous. But they do. They light up. Yeah, look at that. See that little white dot there and a little white dot there? Those are the lumens of the vas deferens. So you can see them beautifully in T2. Here is the prostate, also lights up in a T2 weighted. I don't know particularly why, but it does. Here are crus of the penis, corpus spongiosum, and bulb of the penis lighting up in a T2. They largely have non-flowing blood in them, so maybe that's why they light up, but they do. And this is just a coronal section showing in T1 and T2 the two crura and the bulb of the penis, and as we come forward, the two crura are approaching one another, and will eventually join to form the corpus cavernosum, and the bulb will narrow down into the corpus spongiosum. I thought in a woman, this is obviously her uterus is all messed up here with this condition, which that's not what, here's her bladder. But I thought maybe these would be the two crura of the clitoris, and these might be the bulbs of the vestibule. And as we come forward one level, I thought maybe the two crura of the penis have now joined, of the clitoris, sorry, to join and form the corpus clitoridis. And this, I thought was the deep dorsal vein of the clitoris, but I'm not sure about that either. So I just thought it was. What's this? Here's just some pathology. T1, T2, and it just shows an enlarged right seminal vesicle, the seminal vesicles, but you can see it on the T1 as well. Rectum, bladder, the two seminal vesicles in eccentric bow tie. Here is a prostatic cyst seen in a T2 median sagittal section. Here's the bladder, prostate can sit right here. Here's a cyst. And here's the rectum behind it. All right, this is the last thing. This is a volume rendering of a person angiogram of the aorta and lower vasculature. So you can yell out to me what you think is wrong with this person. I'll play it again. Actually, maybe I'll put it in the pause mode. So here's the straight-on anterior view. Something is really wrong. Here's a side view. Something is also wrong. A second thing is wrong. Here's a posterior view. We see the first thing that we saw really wrong again. And we're wrapping all the way around to another side view. Second thing is wrong. And then we're back to the beginning. So anybody want to venture what they see is wrong? First thing, second thing, or anything? You just yell it out. I mean, it's so obvious.
Occluded left common iliac.
Yeah, left common iliac. There is no, the left common iliac is completely occluded in this person, completely occluded. And this is all being filled by all the rest of it. I mean, here's the external iliac right here on the left side. Here's the internal iliac on the left side. That's all being filled by anastomotic flow from the other side, to be honest with you. All right. Remember this thing up there? So that's one thing is right. Person said common iliac occluded, left side is right. Anything else out here?
The IMA occluded as well?
Perfect. The IMA is completely occluded at its origin, right here. It's also being filled. It's being filled by the marginal artery of Drummond or the arc of real lamb. All right? But it's not getting anything from the aorta. Right? So it shows you that anastomosis can fill vessels that are not being fed normally. There's also a little kink right up there in the top in the left renal artery as well. Now, there's an artery we see here, right here, that you normally never see in these things. And it looks to me like it's coming off of the left external iliac. So what do you think that artery is that we don't see on the right side at all, obviously? There's only two branches of the external iliac. This is one of them. Well, the inferior epigastric is probably the beginning. The inferior epigastric runs towards the belly button. Yes. This is the deep circumflex iliac. You never see this sort of thing. But it's probably very big in this person, again, because of the anastomosis. It's one of the things that's helping to fill the vascular, because the anastomosis of the deep circumflex iliac with intercostal arteries and lumbar arteries, it's being filled in a retrograde fashion and helping to fill the occluded left iliac system. So I just thought that was interesting.